Hi, everybody. This is Dr. LePage. I'm running a little late and trying to upload the PowerPoint to the course. So give me just a minute. Hi, everybody. It's Dr. LePage. I'm so sorry. I thought I was scheduled at 9 o'clock tonight. I was still trying to upload and get it sent to you all. So I'm going to have to post it after the session, but I'm going to share. Are you all able to see it? Are you able to see the PowerPoint? Anybody? Are you able to see the PowerPoint?
Yes, please.
You are. Okay. Thank you. So let's talk about some EKG changes with acute conditions. Um, when patients have a lot of electrolyte imbalances or actually coronary artery disease, we're going to see some EKG changes. So let's take a look at our learning objectives. Identify the EKG changes in acute conditions such as STEMI, non-STEMI, hyperkalemia, hypokalemia, and electrolyte disturbances. So identify the treatment modalities for the EKG changes as they relate to those various medical conditions, and then identify the medications and treatments that are used to restore cardiac perfusion, normal EKG rhythms when these patients have these STEMIs, which are those ST elevated MIs, the acute MIs, and your non STEMIs, which lots of times patients who present with angina type pain are considered to have non-STEMIs because their EKG does not show any changes immediately. Hyperkalemia and hypokalemia. We've talked a lot about that in a lot of different sessions with medications, with urinary medications with urinary disorders, kidney disease. That hyper and hypokalemia are very common causes of EKG changes and cardiac issues. And if you go back to anatomy and physiology, you'll think about what are those electrolytes that help the heart work and what works on muscles, because the heart is a muscle. And then identify documentation. So, steps to ask when you identify a rhythm, back to the basics. So, if we're back to identifying our EKG rhythms, remember we're going to ask ourselves, is it regular or irregular? Is it fast or is it slow? Is there a P wave for every QRS? Is that QRS wide or bizarre? And as you can see in this one, which is normal sinus rhythm, the QRS complex is narrow. And we have a P wave for every QRS complex. It is regular and it is a normal sinus rhythm, which is 60 to 100. So, learning the definitions of the rhythms will be very helpful in helping you identify them. So, if you can identify the normal rhythms, then you can identify the abnormal rhythms. I just did a review on the calculating heart rate. You look at your 6-second strips, and if you see the notches where the arrows are on the EKG, that is 6 seconds. And you multiply that by the number of QRS complexes you see. So 1, 2, 3, 4, 5, 6, and 7 multiplied by 10. So that gives you a heart rate of 70 beats per minute. Sinus rhythm, again, by definition, we have a P wave for every QRS. They are regular, which means our QRS complexes are going to map out and be even. It is not fast or slow, it's normal between 60 to 100 beats. And the QRS is not wide or bizarre, it's narrow. When we talk about ST elevated MI, which is your STEMI, you have a complete coronary occlusion that is causing chest pain, and places these patients at greater risk for a cardiac event such as ventricular fibrillation. There is no perfusion to any area of the heart when this patient has ventricular fibrillation, and there is no perfusion to any body system or tissues when they're in ventricular fibrillation. It does require, STEMIs requires pre-hospital and post-hospital care. Not every patient who's experiencing a STEMI will evolve to ventricular fibrillation, but most often when these patients come in ventricular fibrillation, it's because they have had a STEMI. So that clot is going to occlude that coronary artery, and it's going to cause that chest pain, and there's going to be no perfusion to that area of the heart. And when we look at our EKG tracing, that ischemic area, or that area of the heart that has died off, is representative in our T wave. So, medical conditions that can alter EKG tracings: hyperkalemia, hypercalcemia, and hypermagnesemia, as well as your STEMI and non-STEMIs. When we talk about hypo versus hyperkalemia, the normal potassium level is 3.5 to 5. So for hypo, it's going to be a potassium level less than 3.5. Causes could be vomiting, diarrhea, excessive laxative use, some of our adrenal or genetic conditions, and then, of course, our loop diuretics. We talk about those a lot. What can cause hyperkalemia? And the definition is a potassium level greater than 5.0. High potassium diet. So, knowing what types of foods, your bananas, there are lots of foods. A lot of your melons have potassium in them as well. Potatoes is a big form of potassium. And then medications that block that kidney's ability to secrete the potassium, such as your potassium sparing diuretics, which is opposite of your loop diuretics. And then a lot of times renal disease can cause hyperkalemia as well as DKA can also cause it. So, signs and symptoms of hypokalemia: constipation. These patients can have heart palpitations, extreme fatigue that results in muscle spasms, a lot of numbness and tingling in their extremities. Muscle cramps is one of the biggest signs that we see. And then it can lead to paralysis. They can also have increased urination, polyuria, and polydipsia, increased thirst. So, monitoring these patients is going to be key to keeping their potassium levels normal. We all know the body needs potassium to keep those muscles, nerves, and the heart working. So, it also needs potassium for those healthy digestive system and bone health as well. So, the low levels can affect all of those things: our bones, our muscles, and our heart. So, looking at an EKG tracing for hypokalemia, remember we talked about the P wave is here. In hypokalemia, remember our isoelectric line is right across here. Where does that EKG tracing, where should it be? It's called our isoelectric line. Those P waves in hypokalemia are amplified. They're pretty big. Those are big P waves and U waves. They're prolongation of that PR interval. They have a widespread ST depression. And remember, Q, R, S, T. So typically, this is elevated. This or amplified in a positive manner. In your hypokalemia, this T wave is depressed. And then we have a very pronounced U wave, which is right here. Um, there is also a prolonged QT interval, which would be your Q to T, which would be right here. So we can see those. In hypokalemia and also hypermagnesemia, we see what we call torsades de pointe. And it's actually ventricular tachycardia. And we've discussed tachycardia previously, but these are polymorphic, which means they don't look the same. If you remember when we talked about ventricular tachycardia, they were normal. They looked the same. They mapped out. Again, the QRS complex was wide. These are a little more narrow, and you see how they're peaked and they're pointed, which is how we got the name torsades de pointes. So it is a type of polymorphic ventricular tachycardia, and it's characterized by gradual change in the amplitude. So you see how this looks a little different than this, but it's still ventricular tachycardia. And it's not staying on that isoelectric line, which is kind of that imaginary line right across here. About 50% of the patients that develop torsades de pointe may be asymptomatic, but it can cause death in about 10% of the patients. So recognizing that these patients need potassium and they may need some magnesium as well. So treatment for hypokalemia, it depends on how low the level is of potassium, how much of the replacement, whether we're going to do oral or IV potassium. Definitely want to cardiac monitor these patients to make sure they don't develop any lethal arrhythmias. Monitor their renal function, increase their fluid intake if we're giving them oral potassium. Nursing interventions with oral potassium, make sure you're not crushing it. And we never, ever, ever push potassium IV. So it's never ever given IV push. It's always hung as a piggyback, or it's always in an infusion, but we'll run it over about 30 minutes to an hour, depending on the dosage and the amount of fluid. And then in response to that, we need to monitor their magnesium levels. Signs and symptoms of hyperkalemia are going to be somewhat of the same, right? Muscle weakness, muscle twitching, numbness and tingling in the extremities, nausea, vomiting. They can have an irregular heart rate and also irregular EKG rhythm. Sometimes these patients develop shortness of breath, and we are trying to decrease that potassium level, which is our goal in hyperkalemia. This is just a schematic of some of the symptoms of hyperkalemia. The biggest and most priority would be to prevent those cardiac arrhythmias. Some of the changes that we might see in hyperkalemia, again, we see what we call peaked T waves. Your T waves should not be on the amplitude when we're looking at them. They should not be higher than that QRS complex. And if you see these, you see they're kind of peaked T waves. They are, and the amplitude is a little higher as well. As they progress, or as the potassium level increases, so can the changes in the EKG. And we'll talk about those in just a minute. So we may give them some loop diuretics, especially if they're fluid overload as well, on top of that hyperkalemia. We might do medication dosage adjustment because there are some medications that cause hyperkalemia. We might give them some potassium binders. One of those would be the K-exalate, that sodium polystyrene sulfonate. That gets rid of the potassium through the GI tract. So it's going to bind to it and excrete it in the form of the stool. Sometimes these patients may need dialysis, and we may give them some calcium gluconate as well. So when the potassium gets higher and higher, these patients can progressively develop worsening changes in their EKG in what we call a cine wave pattern, where it just looks like a bunch of oceans going across. That QRX complex and that tall T wave, they're going to produce kind of like a waveform like you see in the top one. If the potassium is really, really high and goes untreated, they can develop into ventricular fibrillation. And then we're in a cardiac arrest situation, and we need to do our ACLS measures, and we need to defibrillate this patient and start CPR because there is no perfusion anywhere. So if they develop that ventricular fibrillation, we're going to start CPR. We're going to defibrillate. We're going to administer epinephrine, which is 1 milligram every 3 to 5 minutes. And you see, I put a picture of the epinephrine that comes. They're called Bristagets. And that is what you will find in the crash cart. And then amiodarone as well, which is your antiarrhythmic. That may be 300 milligrams for the first dose. And the second dose is going to be 150 milligram bolus. And then we may, if the patient has return of spontaneous circulation, we may put a continuous infusion of that amiodarone. So I know that was a lot. I still have a little more to talk about, and then we'll do some questions. Does anybody have any questions so far? No questions? Okay.
Please,
So let's,
I'm
yes,
sorry. I want to know what is shockable rhythm and non-shockable rhythm.
you want to know what is what?
Shockable rhythm.
I'm having a really hard time hearing you.
I mean,
Oh, a shockable rhythm?
yes, please.
So the only shockable rhythm is ventricular fibrillation, which is this rhythm here, this bottom one, ventricular fibrillation. That is
Okay.
the only shockable rhythm. We
Okay.
can cardiovert, which we deliver electricity, but it's not at the same number of joules or amount of electricity that you would defibrillate somebody.
Hmm. So in VFib, we first do the CPR to get a pulse before we defibrillate, right?
So, yes, you're going to start CPR immediately, but you also need to get that defibrillator. That patient needs the defibrillator, but while you're waiting on the defibrillator, you need to be getting that circulation going. So
So,
think think about the reason why we teach the community and the layperson CPR, because most often when patients collapse and pass out due to a heart attack, they are in ventricular fibrillation. The end goal is we need to get defibrillation on this patient. However, there's not always a defibrillator right there, right? If you're at home, you don't have a defibrillator. So we teach lay people to do CPR. If you're asking because you had a question related to that, the question most often is going to be defibrillation is what you ventricular fibrillation requires defibrillation. But when we're talking about it, that's the priority. But if you're in the hospital or if you're in a out somewhere and there is no defibrillator, we need to start CPR until we get that defibrillator. Does that make sense?
yes, ma'am.
Can the RN start CPR without an order? Absolutely. As long as you are BLS certified, and any person in the hospital who is any person who works in a hospital has to be BLS certified. Even the housekeeping people in most hospitals are required to take BLS, which is your basic life support. So your ACLS, advanced cardiac life support, those nurses can run a code depending on what area you work. So, being an emergency room nurse, if I was the first person in the room, we are able to start some protocols under ACLS. So, but yes, absolutely. Anybody can start CPR as long as you're BLS certified. Does that answer all the questions so far? Does anybody have anything else? Okay, let's talk about hypomagnesemia and hypermagnesemia. So we know normal magnesium is 1.7 milligrams per deciliter to 2.2 milligrams per deciliter. Magnesium is another important electrolyte. It is a mineral because it does carry electrical charges. So anytime we think electricity, we think heart, right? It functions as a cofactor for a lot of enzymes, and it's going to bind them together to help regulate a lot of our body systems. So, what does magnesium help with? Muscle and nerve function. It helps with blood pressure regulation. It helps with blood glucose control, protein building, nerve impulse conduction, so our central nervous system, muscle contractions, heart rhythms, and it also helps with bone strength. When we talk about hypomagnesemia, what are some of the causes? Increased GI output, so your nausea and your vomiting. Increased urinary output, it does get excreted in the urine. Acute pancreatitis can cause hypomagnesemia. And then extended use of your proton pump inhibitors and also some of the antacid use. Some of the antacids can also cause hypo and hypermagnesemia depending on how what brand or what type of antacid they're using. So with our hypermagnesemia, some of the causes can be kidney failure where the kidneys are not able to excrete it. Some could be dialysis. So they might get cause too much hypermagnesemia by pulling off too much of the fluid. Addison's disease can cause it, as well as irritable bowel syndrome. The other type of medications are a lot of your lithium based medications. So remember, our patients who are a lot of our patients on antipsychotic medications are taking some lithium based medications. So we really need to monitor their electrolytes. In our EKG changes with hypomagnesemia, we see a depression of that ST segment. So right here is where you're going to see that depressed ST segment, and the amplitude is going to be more so on that baseline. So it's going to be on that isoelectric line as well. We also see the torsades de pointe and ventricular tachycardia with hypermagnesemia. And again, you see how these waves are pointed here at the bottom. So I apologize. I thought I was on at 9 o'clock, and I was not completely finished with this presentation. I will get it posted for you all, but I do have questions um, on there. If you will go through the questions, is there any particular questions you have for me right now? Any concept that needs clarification? All right, let's do some practice questions. A lot of times the practice questions are good. Let's go through the rationales as well because that gives us a lot of information. So, a nurse is assessing a client when they notice the following rhythm on the cardiac monitor. Which is the nurse's most appropriate action? So, what is the priority for this? This is a priority question because we see the word most. First, we have to identify that rhythm. What rhythm is that?
Asystole.
Asystole. Yep.
Basically, yeah.
So, what do we need to do for this? And if you're not sure about it,
CPR.
okay, but CPR isn't one of our answer choices.
So
So
C.
We're supposed to get epi, I think, but then you follow it up with amiodarone, I think. I don't know. I think.
Okay.
Unless I'm getting confused with another one.
You might be, but we do give epi. We do, but epi isn't an answer choice. So if you're looking at
C.
these answer choices,
This is C. Defibrillate immediately.
This
okay,
one we assess patient.
say again.
This is
We
my
assess.
answer would be C. Defibrillate immediately because it's already did. This is already flat.
So
No, we need to assess patient.
you
If
have
patient,
nothing to defibrillate. There is no rhythm. There
There's
is
no
nothing.
rhythm.
So this patient is dead, and you can't get much deader than dead.
Right.
So defibrillation, remember, if I teach you guys anything, we defib VFib. That is the only shockable rhythm by defibrillation. If the patient is in ventricular tachycardia without a pulse, we defibrillate that because it's considered VFib. So we're going to rule out C. We do not defibrillate asystole. We might administer amiodarone, but that's not the first line medication. But going back to what is amiodarone? Amiodarone is an antiarrhythmic. This patient has nothing. So there's no arrhythmia there to administer the medication. It's not going to do anything. So ventilate the patient with 100% oxygen. Well, that's still not going to do anything to the patient because there's nothing.
It's A.
It's
It's
A.
A.
Yep.
It's A. Prima's confirmed that they're officially dead. Got it.
Yes.
Okay.
Yes. So understanding why those other answer choices are incorrect is important as well, because if you get a question like this and you're not sure, take the time to pick it apart and eliminate the other answer choices, right? So even though you all said start CPR, give epinephrine, those aren't your answer choices, right? Those are correct. That is the correct treatment for asystole, but those aren't the answer choices. So we have to go with what's most appropriate with the answer choices that we have. A client presents to the emergency department with chest pain. The EKG is shown below. Which of the following diagnosis is most likely? So, can the very bottom one, this lead to, is your rhythm strip. So pay attention to that. What does that look like? So going through our steps, is there a P wave for every QRS? Yes, there is. And is it fast or is it slow? Well, it's a little fast. Is it regular? It's regular. It is regular. And is that QRS wide and bizarre? Well, the QRS is not necessarily wide and bizarre. This is your Q, this is your R, and this is your S, and this is your T. So this is what we call an ST elevation, because you see it kind of runs off and it's quite elevated. The other like name that we use for this is tombstones. If you ever, they look like tombstones if you go to a grave site, right? They kind of look like tombstones. So I really don't think that NCLEX is going to ask you to read a 12 lead. This is a 12 lead EKG. May ask you to read a rhythm strip to identify that this is a STEMI or not. But this is asking you to identify where that STEMI or where that occlusion is at in the heart. So this is not an entry level question. Working in an emergency room or a cardiac care unit, you might get this question, but this is a good question to look at because the most common type of heart attack is that inferior STEMI. And if we're going to pick this question apart, it's specific to that ST changes and it's in the leads that we see it in. A nurse is caring for a client with chronic kidney disease. Which
Professor,
of the
please, how
following,
does lateral STEMI looks like?
ma'am?
How does lateral STEMI looks like?
How does what?
B, lateral STEMI. How does it looks like?
The lateral STEMI?
Yes.
Well, it's going to look like that. It's just going to look like that in different leads, because lead 1, lead 2, lead 3, AVR, AVL, AVF are looking at different areas of the heart. It's still going to look like a STEMI with that ST elevation, but the leads that you see it in are going to be different. It's going to look the
Please, what's
same,
the
but
answer? Please, what's the answer?
the answer was C.
All right, thank you.
A nurse is caring for a client with chronic kidney disease. Which of the following EKG changes may be seen in the client with potassium levels of 6.5? So first off, we need to
Pick
determine, is
T-wave.
that normal?
A.
Pick T-wave. A.
A.
Yes, it's A. Those tall peaked T waves, right? Because it's hyperkalemia. The widened QRS complex is going to be your ventricular tachycardia, and your prolonged PR interval is going to be a type of heart blocks. Your flattened T waves is what we see in hypokalemia. A nurse is caring for a client on furosemide. Which EKG change is most likely in this client?
B.
C.
Yes,
It's C.
It's C. Yep. It is C. We see your U waves because we see U waves with hypokalemia, and that is a common side effect of furosemide, right? Because it gets rid of that potassium as well. ST elevation is your MI. A shortened QT we see with hypercalcemia, so calcium levels, and your peak T waves we see with hyperkalemia. A client diagnosed with a non-STEMI is being managed medically. Which interventions are appropriate? So this is a patient who's having a heart attack, but it's not an acute heart attack right now, and we're not seeing ST elevation. So what's our treatment for a patient who's experiencing chest pain?
D. Use sublingual and aspirin.
So this is a select all that apply question.
Okay.
So there's going to be more than one answer choice.
So go for A, B, C, and D.
Yes.
Okay, so I heard A, B, C, and D.
Yes.
So let's take a look at this question. This non-STEMI is being managed medically. So is B a medical, or is that an intervention that we'd be doing for this patient? Not every patient that comes
I
in
would
with
say A, C, D, and E.
So why would we give them a thrombolytic? What is a thrombolytic going to do?
To prevent clotting.
For the clot.
To prevent clot.
So, in fact, thrombolytics are actually contraindicated in a non-STEMI. So the correct answer for your non-STEMI that's being medically managed, we are treating them with MONA. Remember, morphine, oxygen, nitro, and aspirin. So your correct answers are A, C, and D. We are not taking them to the cath lab for that PCI because that is an interventional intervention, right? And this patient is being managed medically. So if it's not an acute MI, they just may have some narrowing, and this patient may need open heart surgery down the road, or they may need to be monitored to see how bad that occlusion is or gets. In your non-STEMIs, thrombolytic therapy is contraindicated. And even in your STEMIs, the best treatment is to get them to the cath lab for that PCI. We use thrombolytics for strokes and thrombolytics for pulmonary embolisms, but not typically your STEMIs or your non-STEMIs. Does that make sense?
Yes, ma'am.
So a client has a potassium level of 6.8 milliequivalents per liter. Which is the nurse's most appropriate action?
C.
Prepare to administer calcium gluconate IV.
Yep. Yep. So if they already have a high potassium, we're not going to do that. Was kind of an easy kind of question in my eyes. Even if you didn't know that calcium gluconate was the treatment for hyperkalemia, all of those other things, well, A and D contain potassium. We're not going to give them more potassium if it's high, and teach the patient to avoid bananas. To me, I call that a do nothing answer choice. That's going to do nothing for this patient right now who has a high potassium level, right? We need to treat that high potassium level because that's pretty high, 6.8, right? What type of rhythm would we be monitoring this patient to ensure that they don't develop?
T wave.
All peaked T wave.
Peaked T waves or ventricular tachycardia. Yep. A client with hypomagnesemia is at risk for which dysrhythmia?
Torsade de Pointe.
Yep.
Torsade points.
Yep. It's that polymorphic ventricular tachycardia. Asystole, remember, is a flat line. Your atrial fibrillation patients don't magnesium doesn't affect the atrium so much, it affects the ventricular or the ventricles. And then ventricular asystole is the same thing as asystole, right? A nurse is caring for a client whose EKG is shown before. It shows those tall peaked T waves and widened QRS complexes. Which lab is most likely?
Potassium.
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 Yep.
Potassium. B.
And you see those peaked T waves in the different leads. So your 12 lead EKG, we put the leads on and we get an EKG, right? And it's looking at the heart from 12 different views. So that's how we can identify where that STEMI is occurring, depending and correlating the leads to the different views and what area of the heart those leads are looking at. The nurse is aware that which of the following EKG findings is most indicative of an ST elevation MI?
C.
T segment elevation.
ST segment elevation.
Yep.
Yeah.
Yep. That's your acute MI that's occurring right now. If they're having a normal EKG but an elevated troponin, could they still be having some type of heart issues? That would be considered a non-STEMI.
Non-STEMI, yeah.
Yep. The elevated troponin. So your troponin levels are your very cardiac specific enzymes, and they circulate through the heart. So if they're having an elevated troponin, we monitor serial troponin levels, typically do them every 4 to 6 hours. So if the patient is having chest pain, comes in having chest pain, and the EKG, first thing we do is get an EKG, and there's no ST elevation. We then draw blood work, and we see a slightly elevated troponin. That means they could be starting to have some occlusion, and it's considered a non-STEMI. We're going to medically manage that patient because we don't want that occlusion to evolve to more occlusion. So we monitor these these troponin levels every 4 to 6 hours. Sometimes they rise. They are very specific to the heart, but it doesn't an elevated troponin level doesn't always mean that the patient has had a STEMI or a non-STEMI. A troponin level can be elevated with what type of disease process might you think?
MI?
Well, that's your STEMI, your MI. What other than an MI? What other disease process that affects the heart could your troponin might be elevated? Heart failure can elevate
Kidney
a troponin.
failure?
Kidney failure.
I don't know that kidney failure will elevate the troponin because it is cardiac specific.
Ribomyolysis.
Rhabdomyolysis can elevate the troponin level. Heart failure, or if the patient has a pulmonary embolism, can all elevate the troponin level.
I'm sorry, what was the answer?
For this one?
C.
Yeah.
The answer is C.
Thank you.
A nurse is caring for a client with hypocalcemia. Which EKG findings would be expected in this client? So this is a select all that apply. What does calcium do in relation to the heart?
B, shortened QT interval, T wave inversion.
So what role does calcium play on the heart?
A and D, particular dysarrhythmia and the prolonged QT interval.
So calcium, the role that it plays on the heart is it helps with electrical conduction and muscle contractions. Because remember, our heart is a muscle. So we're going to have a prolonged QT interval, and we're going to have a ventricular dysrhythmia because of the repolarization. It takes a little longer. And that's what's going to make that prolonged QT interval. The ventricular dysrhythmia because of the conduction and the muscle contraction on the ventricles. Does that make sense?
Yes, ma'am.
Can you repeat the answers for me, please?
It's A and D.
Thank you.
A nurse is caring for a client on cardiac monitoring. What should be included when documenting a dysrhythmia episode? And this is a select all that apply.
ABC.
Excuse me, ABC. So, would we treat a dysrhythmia episode? So, the correct answers are A, B, C, and D. Think about what's important. It's important to know how we obtain that rhythm. And sometimes some of our cardiac patients are on telemetry. So, did we identify that rhythm as the nurse, or did the monitor tech tell us what rhythm it was? So, if we got the information from the monitor tech, we need to document that as well. What was the time of the occurrence? What was the patient's assessment or response to it? And what was the treatment we give? Sometimes we may just need to put oxygen on them. Sometimes we may need to give them medications. But we need to document that response and we need to document our assessment as well. We don't need the provider's diagnosis because that's already on the chart and that's not really anything to do with nursing and what we did for this patient. It's not going to affect the care that we render to this patient. Does everybody see that?
Yeah.
A nurse is caring for a client who has been diagnosed with a non-STEMI. Which of the following findings might be present? This is a select all that apply. So some words here that you might not be familiar with. ST elevation in two contiguous leads. That means two leads that are looking at the same area of the heart. So if we're having a non-STEMI, we're not going to see ST elevation, right? So we can rule out answer choice B. Reciprocal ST depression means that we see ST depression in one and ST elevation in the other. So we can kind of rule out that because it's a non-STEMI, right? So we can rule out B and E. How many people think you'll see an elevated troponin in a non-STEMI? Yes.
I think so. A.
Yes, you would see an elevated troponin, right?
Yes.
How about T wave inversions?
B also is T elevation.
Elevation, yes, you can see.
Yeah, you might see T
B.
wave inversions because they may have already had ischemia.
Yes. Yeah.
And
C.
they may have chest pain at rest, which is the whole reason
The
why
whole
they
reason.
come in, right?
And then
Yeah.
E. Reciprocal, right?
So your answers are A,
A,
C,
C,
and
and
D.
D.
And what? A, C, and
D.
A, C, and D. Two-way inversion.
A, C, and D.
D. Oh, okay. Thank you.
A client with chronic kidney disease presents with muscle weakness and a peaked wave on EKG. What is the nurse's priority intervention?
A.
A.
Yes.
Administer IV calcium gluconate.
Why would we not give them K-Exolate?
It will worsen the
Increase the potassium.
The potassium is low.
Cause of cardiac dysrhythmias.
Right. Well, not necessarily, but also they have muscle weakness and those peaked T waves. And typically the peak T waves are indicative of severe hyperkalemia. So we need to do something other than just get rid of it through the GI tract. And this patient has muscle weakness. So we may, they need that IV calcium gluconate. A nurse is aware that after a client returns from cardiac catheterization for a STEMI, which documentation is priority?
Letter C.
C.
C. You need to check.
C. Yes. So remember, when they go for a cardiac cath and it's a big lumen, a transducer that gets placed into probably the femoral artery or the radial artery. So we need to make sure that these patients have pulses distal to the area, and to make sure that we're doing good assessments on those areas, and the patient isn't developing a hematoma or bleeding. Last time of a bowel movement, that really, that's insignificant right now. Medication reconciliation, that should have already been done. And then client education about home care. Typically, when we're talking about priority questions, we're not going to answer with an education question unless it's a question related to patient teaching. What is the priority patient teaching? Then we would answer with a teaching answer. But typically your priority questions are not going to be not going to be answered with a teaching or an education. A client on a loop diuretic has new onset premature ventricular contractions and reports muscle cramps. The lab shows a potassium of 2.9. So is that normal?
It's cannot.
No,
It's
please.
what?
It's
No,
below.
potassium is 3.5 to 5.0. 2.9 is low.
So it's low. What should the nurse do first?
Notify the provider, anticipate IV potassium replacement.
Absolutely, because
I
that's
think-
pretty low. We need to get that up, right?
Yes.
Are we going to administer that loop diuretic?
No.
No, absolutely not.
Potassium lower.
Yeah, it'll lower the potassium. Absolutely. A nurse is caring for a client whose EKG is shown below, and that is torsades de point.
IV magnesium sulfate being administered.
A.
Okay, then. You got that, right?
That's good teaching. I love that.
Do what?
I love that. It's good teaching.
So why would we not defibrillate this?
We only defibrillate in V5.
Well, yeah, we do only defibrillate VFib, but if they did not have a pulse with this, we would defibrillate. Atropine, we're not going to give them atropine because what does atropine do? Increases the heart rate, right?
Decrease.
And sodium bicarb, that's a pretty much nothing kind of. In this case, it's not going to do anything, right?
Right.
So that is all I have. What kind of questions do you guys have for me related to this? Nothing? I apologize. I really thought I was scheduled at 9 o'clock. And I was finishing up most of it. Otherwise, you would have had a little more information. Any questions? Anything I can help with? Y'all are quiet tonight. You are welcome. Yes, you have a question? When is the next session? There might be another one after me. I'm not sure.
When is your next session?
I'm sorry?
When is your next session?
My next session is, let me look at my calendar so I give you the correct information. I have been displaced from my house. We're going on 6 weeks now. So I'm very discombobulated. My next session is at 9 o'clock on the 22nd. And then I have another one at 9 o'clock on the 24th. And 9 o'clock on the 31st.
Thank you.
You're welcome. Yes, that's Eastern time. So when you meet a question with priority, which criteria will you use to answer which client should be seen first? So the kind of rule of thumb for your priority questions is airway, breathing, circulation, and disability, A, B, C, D. So think about if they're a patient with an airway problem, if there's not a patient with an airway problem, or if the airway is stabilized, look for a patient with a breathing problem, and then go down the list of that. So if you had a patient that came in, if you had a child, a 2-year-old who was drooling and tripoding, a 42-year-old patient having an asthma attack, a 57-year-old patient who came in with chest pain, and then a 76-year-old patient who came in with stroke symptoms, which one of those would you see first? Because they all have A, B, C, D, right? Which one would you see first? Anybody?
The stroke patient?
So if we're going to go by airway, breathing, circulation, and disability, disability is your neuro.
I think that the child in a tripod position.
The child in the tripoding position that's drooling. That child has an airway problem. Yep. And then which patient would you see? So now you have the 50-something-year-old having chest pain, the 40-something-year-old having an asthma attack, and the 70-something-year-old with stroke symptoms.
And I'll go to the asthma.
Yep.
Because of bronchospasms.
Yep. You would go to the asthma, at least just assess She may be stable, right? She may be having an attack, difficulty breathing, but she's okay right now. So then I move on to my chest pain patient, right? And then my disability patient, which is the stroke symptoms. What's the best way to answer a mental health question? So there's no clear-cut way with any of these questions. Again, you would have to look at the scenario. Again, look at airway, breathing, circulation, and then patient safety. Which criteria do we know? These questions need you to take an action first and notify the healthcare provider. So if you get a priority question that says that gives you an answer choice to notify the healthcare provider, ask yourself, do I have all the information I need to talk to this doctor to give him a clear picture of this patient? So if you're missing assessments, an assessment piece in the stem of the question, don't call the provider. We had that one question where we had to call the provider, right? Let me go back to it. So the patient with the new onset of premature ventricular contractions, and he's having muscle cramps, and he's got a low potassium, I need to call that doctor and anticipate the order for potassium, because that patient can get worse. I need potassium, right?
Please, I have a question.
Sure.
Please, when it comes to managing a sickle cell anemia client with vaso-occlusive crisis, is the priority when they say with chest tightness or with pain, is the priority to administer fluids like 0.9 or to give oxygen?
So I would have to see the exact question. Anybody who has sickle cell who comes in with chest pain is considered an emergency. Chest pain or high fever with sickle cell is not good. So I can't answer your specific question because I'd have to look at the question. But you would have to look at what else is going on in that scenario. But anytime a sickle cell patient comes in with chest pain or a fever, it's a medical emergency. Mental health, somebody put in here mental health, use Maslow's. If it's a prioritization, you can use Maslow's, but also use safety. What is the patient's safety, especially with your mental health? I need clarification on circulation. Is it only involving the cardiac system? Well, circulation is also fluids. Circulation is perfusion. So, yes, it may or may not be specifically the circulation. If a patient comes in with a low blood pressure and it's a priority question, that would be a circulation issue because they're not perfusing, right? So, think about what the concept of circulation is. A patient said she wants to go home, and she said to you that the provider said she can't have hospice's care at home. What will you do? Well, you can educate the patient. What I'm not real sure why the provider would say she can't have hospice. There's criteria for getting into hospice. So I'm not real clear what you're asking on that. Kindly enlighten me on how to answer select all that apply questions correctly. So I tell students to reword the question and then narrow it down. If you're looking at a question such as a nurse is caring for a client who has been diagnosed with a non-STEMI, which of the following findings may be present? So go through and weed out. Ask yourself, what is my patient going to present with, or what is my patient going to look like if they're having a non-STEMI? So ST elevated troponin levels, right? That's a positive. So ask yourselves, is this a sign of a non-STEMI? Kind of reword it depending on what the question is asking, and ask yourself yes or no questions to kind of weed out the questions. Is bleeding take over circulation? Well, bleeding is a part of circulation. If somebody is hemorrhaging, their circulation is going to be low. So bleeding is kind of a concept under circulation. Does that make sense? And it depends on where they're bleeding. So a priority question might be a patient who has a history of AFib presents with a head injury. Well, that's going to be an emergency, because if we know as a nurse, and our critical thinking tells us, if they have atrial fibrillation, they're going to be on a anticoagulant. And if they've now hit their head, or they have facial scratches or swelling, they may have a head bleed. So that's going to possibly be an emergency. The options that followed was 1, report to authority, 2, report to your supervisor. I'm not real sure what you're for hospice home care. I'm not real sure what you're asking. I'm not sure what report to authority means. I mean, the police, we're not going to report anything to the police. Report to your supervisor, you might contact your supervisor and go from there. I mean, I would need a little more detail to help you with that question. Use your chain of command. If you're not agreeing with a physician, or the decision of a physician, or the patient is not, you can always contact the charge nurse, and then go up the chain of command. Kindly talk about case study, please. What kind? I mean, what do you mean by case study? How to answer a case study? Because your case study is basically a patient. We do a lot of case study questions here, and it gives you the information or a partial chart, and then each question that pertains to that case study is going to be some part of the nursing process, or some part of your care that you're doing in a 12-hour day for that patient. So it may be you need to recognize cues. It may be that you need to hypothesize your cues and plan your care for your patient. It may need that you're going to intervene on that patient. Go back to the information, and what it does is it'll give you timestamps throughout the day or period that the patient is in your care, and how are you going to take care of that patient? Did that help answer? And I'm not real sure what you mean by talking about them, because they're all going to be a different concept. Each case study is going to be a different concept. Any other questions? Was this helpful? All right. If nobody has anything else, I'm here to answer questions if you need help. How do we recognize hypotheses in a question? So, the NCLEX cues and that critical thinking and clinical reasoning is recognize cues, hypothesize those cues. So a hypothesis is basically just a plan. It correlates to the planning stage of the nursing process. So I now think that there's this problem. I recognize these cues that tell me this patient has heart failure. So now I'm going to plan or hypothesize what I need to do about those cues, or how am I going to plan to take care of this patient. So I may put him on oxygen. I may plan to administer loop diuretics. I may plan to put them on a cardiac monitor. That's what that means. What about reduction of risk potential? So reduction of risk potential is anything that can cause harm to the patient. So that's one of the categories of the NCLEX categories. So it would be a patient. It would be a question related to safety. You have a patient who is an older patient getting out of bed and falling. What would you do as the nurse to prevent her from falling? So you may have an answer choice like place this patient on fall precautions, put an alarm on the bed, or put the bed alarm on, put her in a room closest to the nurse's station. Those might be some of your answer choices. And that's to reduce the risk of harm to this patient. I'm going to try and post the presentation slides. Yes, I've already said I would do that. How can we easily differentiate the types of stripes? What do you mean stripes? EKG strips? Is that what you're talking about? So going through those steps that we talked about, is there a P wave for every QRS? Is it regular or irregular? Is it fast or slow? And is that QRS wide or bizarre? And then knowing the definitions of your rhythms is going to help you with those, to go through your steps with every rhythm. I'm sure the EKG strips like atrial fibrillation and the rest. So I'm not real sure what you mean by that. I'm sure the EKG strips like atrial fibrillation and the rest. You're sure of those? Then if you're not sure of the other ones, use your steps. I mean, I've been cardiac my entire career and emergency or critical care, and if I can't recognize a rhythm, I still use those same steps. When do you perform cardioversion? So you perform cardioversion if they are unstable in a rapid ventricular, a rapid atrial fibrillation. You can perform cardioversion if they're unstable in ventricular tachycardia. It's knowing the rhythms, and then cardioversion, what's the treatment for it. So anytime somebody is unstable and we need to get them back into a normal rhythm, you're going to perform a cardioversion if that rhythm is shockable or cardiovertible. Your rhythms that are is ventricular tach with a heart rate, a heartbeat, atrial fibrillation, sometimes atrial flutter. Yeah, that is simple. It's kind of simple. I'm hoping I'm making it simple so that people remember. You defib, VFib. That's the only rhythm that you actually shock. When we say defibrillation, it's the same as shock. All right. Well, I hope you all have a good weekend. Again, I'm sorry for getting the times messed up. You all have a good night.